Hello, everyone. My name is Anita Iyer and I run Ekansh Trust in Pune. We are an NGO that works to empower persons with disabilities. We welcome you all to Demystifying Disabilities, which is our video series where we interview medical experts and talk to them about prevention, detection, and early intervention. Today, we are privileged to have with us Dr. Mamta Murunjan, who is a leading geneticist in India. Dr. Mamta, thank you so much for being with us on our video series.
Thank you very much, Anita, for having me for your series today.
Thank you.
Hello,
Uh,
everyone.
The first question that I would like to ask you is what part do genetics play in our predisposition to disease and disability? Why is the field of genetics so important today?
What we are before I answer this question, we need to look at the background of the diseases in India. And what we are noticing, the trend over the past couple of years, is that a lot of these communicable or infectious diseases are on the decline, and simultaneously, non communicable diseases like diabetes, hypertension, strokes are on the increase. So we are witnessing two waves of genetic disorders, one predominantly in newborns and young children, and the other one in adult life. And what we see is that almost 5% of pregnancies result in birth of a child with a significant genetic condition, a congenital malformation, or some sort of disability. Again, about almost 40% of intellectual disability has a genetic basis, like either a chromosomal disorder or a single gene disorder. And as many as one fourth or 15 to 25% of kids dying around, during late pregnancy or after delivery, or even young infants, have some sort of a genetic disorder. So this shows us how much genetics is contributing to the morbidity and mortality in various age groups. And as I said earlier, even these so-called non-communicable diseases like ischemic heart disease and strokes and diabetes, hypertension, do have a very strong genetic predisposition. Even cancers have a genetic predisposition. So, considering all these facts, genetics is at the core of multiple medical specialities and is the cause of multiple diseases or predisposition to diseases across multiple medical specialties. So it is high time we start looking at the genetic basis and finding out the root cause, because many of these, when you talk about genetics, it's always the question of inheriting it, passing it on to the next generation, having multiple family members affected. So if we are going to effectively prevent something that is genetic, then we need to get to the bottom of it.
Right. Thank you so much. You made it a lot clearer for us now. So when we say generation, I guess that also comes from the word gene, probably.
Correct. Yes.
So what are the most common disabilities you see, and can you tell us a little bit about their biological epidemiology?
So if we were to look at the top few conditions genetic in nature in India, the most common would be birth defects or congenital malformations. These are babies who are born with developmental or structural defects in multiple organs, and this as a group would account for as many as something more than 700,000 babies born every year with malformations. So you can imagine the magnitude of the problem. And within this group, the common malformations that we see are babies with neural tube defects, heart disease, cleft lip, cleft palate, a simple, what we call club foot. So these are some of the common malformations. Following malformations, we see Down syndrome, I think, would also be common, and as many as 1 in 1,100 babies born in India would have Down syndrome. Hearing loss is another, I would say, a silent disability, which is very often not suspected, not picked up neither by the parents nor by the physicians. So we know that in India, as many as 1 to 2 in every live born baby has a congenital hearing problem. So apart from these top three disabilities, other conditions which are fairly common are blood disorders like beta thalassemia major, sickle cell disease, hemophilia. We also have G6PD deficiency. Now, traditionally, it was thought that the Parsi community had a high proportion of people having G6PD. But today we know that it's not just the Parsis, but all over India, G6PD is a common condition. And then there are certain unusual inborn errors of metabolism, which are also not very common, but not very rare either.
Okay, thank you. What is the reason for their prevalence in India, and to what extent can they be prevented through genetic testing?
So that's a good question, and I think we need to dwell on this a little bit because of our prevalent socio-cultural practices. So one reason could be the sheer number of people in India with a 1.3 billion population, and every year 26 to 27 million babies are born. So if you look at the sheer numbers, it would be a large number of people with genetic disease being born every year. The second thing would be the high birth rate. So it's common to have three or more children in a family. So that could be another factor leading to increased genetic disorders. And finally, one must not forget the practices of consanguineous marriages.
Correct.
So as there is a group of genetic disorders which are the autosomal recessive disorders, where carrier parents, both parents carrying the same faulty gene, transmit the gene to their offspring. And such recessive disorders would be common in families or in communities where consanguinity is common, like the Muslims in North India, or even Maharashtrians, South Indians, uncle niece marriages are frequent. And talking about consanguinity, there is a lot of endogamous mating, also inbreeding, small communities where they keep, over generations, they are marrying within the community itself. So in such endogamous communities, the proportion of recessive genes is much higher than in the general population. So we would expect that genetic disease, particularly autosomal recessive disorders, would be at a higher frequency in such communities practicing consanguinity or close knit endogamous communities.
This is one of the points that we make in the booklet that we distribute among the Anganwadis and the outreach program that we conduct. We talk about this, but we always get the answer that there have been such marriages in our community, but none of the children have been born with disabilities. We don't think it always happens. There's always a counter argument from the group, and we tell them that you're lucky if it hasn't happened yet, but there is always a chance that it will happen. There are higher chances that it will happen if you continue this way.
Right. So there are some communities where the proportion of consanguineous marriages is as high as 30%. But that just because there is a threat of developing a genetic disease doesn't mean we should not encourage the practice of consanguineous marriages, or rather, let me put it this way, that we should actively prohibit or discourage consanguineous marriages. It's just that being aware of the possibility of having genetic disorders, one would like to look at the family background to look whether there is any hint of genetic disease in such consanguineous matings. And these are couples who should be offered genetic counseling, and maybe advise them to test during the pregnancy to find out if they are carriers. For example, find out whether couple are carriers for beta thalassemia major, or after the child is born, do a newborn screening or a hearing screening to screen for congenital heart defects and so on, just so that even if the consanguineous marriage happens, the offspring is screened on time, so that they go into the management pathway at an earlier age to limit disability.
Will it also help if they get tested, knowing that they are related to each other? If they know, will it help if they get tested even before the woman gets pregnant? Will you
Yes,
be able to tell at that stage?
so definitely, testing can be done for common disorders like beta thalassemia major. So, for example, if we know, just to give you an example, thalassemia carrier frequency among Sindhis is very high. So, ideally, at the community level or before marriage, carrier detection of beta thalassemia can easily be done. Even if it is not done before marriage, definitely when such a lady is pregnant or before they plan a pregnancy, carrier testing can be done. And today, technology is available to do carrier testing for common genetic disease in which we find in India, which is more common in India. But always, whenever you contemplate doing a genetic testing for carriers for a whole lot of genetic disorders, such a couple should always receive genetic counseling to tell them what is being tested, what are the implications of getting an abnormal result, what are the advantages of testing, and most importantly, what testing cannot do or what are the disadvantages.
That's wonderful to know, because this is a point that then we can add when we are talking to our Anganwadi workers, that we are not saying that these marriages should not happen, but necessary steps should be taken to prevent disabilities which can be carried
Yes.
down generations.
And I would just like to add here also that nowadays, in such consanguineous, or for that matter, in any couple, we would advocate newborn screening, which is screening a newborn baby within the first week of life, especially in the first 3 days. And this newborn screening can pick up something like almost 50 to 57 metabolic disorders. Hearing loss
Wow.
can be screened. Screening for congenital heart disease is possible. Even a simple physical examination of a newborn to discover birth defects which are not immediately apparent. So these are some very simple measures which can detect some of the common genetic disorders in the community, whether it's a consanguineous couple or even in a non-consanguineous mating.
Right. Thank you. And how accessible and affordable are these resources? Are they available everywhere? Are they affordable? The genetic testing that you're talking about.
So there are different types of genetic testing. On one hand, we are doing biochemical tests to detect genetic disorders like metabolic disorders. On the other hand, we are doing cytogenetics, which tests for chromosomal disorders. And then today we have DNA based genetic testing. So in a metropolitan city, Mumbai, Pune, Hyderabad, and all the other metropolitan cities, genetic tests are quite accessible. Affordability is always a concern. In India, nothing can be too cheap. But we would like to see genetic testing more affordable. For example, if we are testing a single gene, the cost could vary from 10 to 15,000 to as high as 50 or 60,000. If we are testing multiple genes, a panel of genes, the cost could be 15 to 18 to 20,000. Some tests run into lakhs for a single blood sample, 1.5 lakhs. So definitely there is scope for reducing the pricing, and it's more to do with numbers. The more numbers that are tested, the cheaper the tests. But
Absolutely.
in rural pockets, and in especially in the remote areas, access to genetic testing is an issue.
Okay. Thank you. Um, do you get a lot of patients from the underprivileged areas for consultation? Do you think there is a significant health disparity within India in your field? We just discussed that, although we touched upon that now.
Yes. So I am affiliated with KEM Hospital in Mumbai, which is, as you know, a very
Yes.
large referral center. super specialty center for Western India. And most of the patients who come to KEM Hospital are from the weak, socioeconomically weaker sections of society. So majority or almost all patients are from the underprivileged sections of society, many of them below the poverty line. So it is a challenge for us to arrange for finances for testing, for treating. And definitely, yes, there is a disparity in health as in everything else. So there is one section of the affluent, where costs just don't matter. So I also practice at PD Hinduja National Hospital in Mumbai and the NHSRCC Hospital, which caters to the affluent sections of the society. There is a stark contrast in the type of patients I see in a corporate hospital, whereas the type of patients I see at KEM Hospital. So in the affluent sections, parents are willing to spend, and we do know that in India, 60% is out of pocket expenditure. Public health expenditure is very, very minimal and not as desirable as it should be. So in affluent sections, they are not very, they would
Well,
willingly and readily spend the money. But yes, in poor sections, that is one of the reasons why many genetic disorders remain undiagnosed, for the sheer reason that people don't have the money. And COVID has worsened the situation.
absolutely. In fact, I always say that, CSR funding, sometimes I do feel, running an NGO for so many years, that CSR funding can help in so many ways. Even if they can fund diagnosis and labs, so that they can prevent disabilities rather than donating 100 wheelchairs later or 100
Absolutely.
hearing aids later. Why don't you spend the money on making sure that children aren't born with those disabilities in the first place?
So, you're quite right. We as doctors also tend to get a little frustrated when, the funding all comes for treatment, for procedures, for surgeries, whereas there is no funding for diagnosis.
Correct.
And the question to me as a treating physician, if I don't diagnose a condition, how do I go ahead and treat?
Exactly.
So treating for diagnostics is would be very, very welcome.
Yes, I think we should start pushing for this, together, NGOs as well as the medical fraternity together. We should start pushing for more money for research and for diagnosis also. Prevention, like I keep saying, prevention and detection should come
Absolutely.
before
Yes.
anything else.
And prevention is much cheaper than actually treating.
Absolutely. Thank you
Like,
so much.
just to give you a perspective, if I may, you spend a few hundred rupees in detecting the parents who are thalassemia carriers, and spend a few, say something like 10 to 20,000 in doing a prenatal diagnosis of beta thalassemia major. Whereas if somebody actually has a child with beta thalassemia major, the treatment, which involves blood transfusions every month, iron
Absolutely.
chelating drugs every month, can run into a few lakhs at
If not crores.
private centers. Yes, and it's a lifetime cost. So
Yes,
definitely
absolutely.
treatment is cheaper than, more economical than, the prevention is more economical than treatment.
Yeah, it's also less heartbreaking, isn't it, to have a child with a disability and to watch the child going through so many challenges. It's so much better to just prevent it and to invest
Absolutely.
in prevention. I think we should invest in prevention more than anything else.
Yes, a country like India needs to invest heavily in preventive aspects at the community level, and not
Correct.
just at the family level.
Absolutely. Um, what would your general advice to people who have a hereditary disorder or disability be? Once you know that there is possibility that they may have a child with a disability, what would you say to the parents?
So one thing is, the parents have to be very upfront when they visit the physician. If they suspect something could be genetic, hereditary in themselves or their child, they should be very frank, not try to hide that information, and carry their medical records, even take the family into confidence, many families have more than one affected member, and one unit of the family does not disclose this information to even their close relatives. So the starting point for geneticists is collecting information from such families. So if families are upfront, the families are very frank about this information, we can build upon that. Secondly, preserving medical records is also very important. Very often we find families having an affected child who's passed away. They come to us after the child is no longer there, and we find that they have destroyed all the medical records, so we have no clue where to begin with. And simple things like carrier testing for common genetic disorders, and go and completing the diagnostic workup. Many people they when they are confronted with a likelihood of a genetic disorder, very often there is denial. They go doctor shopping, and in all this process the diagnostic process is not completed, and very often we find parents coming to us in an advanced stage of pregnancy. Now tell us what we can do. We think our child could be at a risk for a genetic disorder, and that can be really very difficult to get a diagnosis in time to decide what is happening, how the pregnancy would progress. So
Yes, that is
they should plan, if possible, plan a pregnancy if they think their baby could be at risk for a genetic disorder. Complete all the genetic diagnostic workup before becoming pregnant, and come well in time during a pregnancy for the tests that are required for detecting genetic disorders during a pregnancy.
You're very right, because we still find people who have disabilities who don't have their disability certificates. There is a digital card that they digitally generated
Yes.
card that they get an identity, yeah, an ID
Yes.
which is called the UDID card, which every
Yes.
person with
Yes.
a disability should have. And it makes so much sense because those records are then permanently maintained on your behalf, and connected to the Aadhaar card as well. I think this is a great revolution, and I wish more and more people would take advantage, because once your records are there, they're permanent. And you
Yes.
can destroy the papers, but you can't destroy what is digitally stored there.
Yes, yes. This is a good move because, as I was telling you earlier, paper records are, the parents destroy them, and very often, in the poorer sections of the society, and migrants especially, things like in a city like Mumbai, which is chronically getting flooded every monsoon, or there are house collapses. Many of the records, medical records, are destroyed in these circumstances. So having a digital permanent record is an excellent move on part of the government. But here again, I would like to stress that you have to have a confirmed diagnosis. So
Correct.
by all means, this should be pursued till you reach the end of the road with a confirmed diagnosis.
Yeah, absolutely. We have many people with the wrong UDID cards also, stating the wrong disability. We have
Yes.
children who are borderline, who have borderline autism, who've been put down, they have this word Matimand or
Yes.
mentally challenged, is
Yes.
still using the term mentally retarded on those cards, sometimes on the disability
Yes.
certificate, sometimes. And that has to really change. And there is a whole process of education, I think, that has to happen through the entire hierarchy.
Yeah, it's not only the society, but I think even the physicians need to be aware of avoiding labeling of a child.
Absolutely.
And just to give you an example, you may also have seen on disability certificates a diagnosis of a label, rather I would call it a label of cerebral palsy. Now
Right.
for many of us, we don't consider cerebral palsy as a distinct disease entity, but I would like to look at it as a symptom of something else that the child is actually having. It could be an underlying genetic disorder. So to the physicians also, avoid labeling, try to get to the bottom and find out what the actual cause for the symptom is.
Absolutely. If you look at the list of 21 disabilities, also, it is quite mind boggling because you have thalassemia, hemophilia, sickle cell also listed. Then you have
Yes.
acid survivors listed. Then you have leprosy listed. and then you have autism listed, and it's a very confusing list. It's also left out so many conditions like diabetes, asthma, etc., which could lead to mobility issues, which could lead to
Yes.
issues with vision and so many other things. Many things have been left out, so it's not a exhaustive list, but it's a confusing one right now, where disabilities have been confused with conditions leading to disability also.
So
So
maybe the list needs to be revised from time to time, because
yes,
we also experience that for a simple thing like, outstation patient coming to Mumbai for treatment, applying for something as simple as a uh, travel concession by railways. They will come back to us, this particular disease is not listed in their list of disorders, so we are unable to avail of
right,
concession.
right.
you know
So
so
it's a
yes.
mobility. So it should either be only disabilities, or then it should be all the conditions leading to disability, which is impossible to list. So I think they should focus
Absolutely.
only on the disability that is caused finally. This is something that I've been petitioning for also through change.org and all that, but I don't know if anyone is reading it. It also has to come from the medical fraternity again, so that we have a
Yes,
very clear list.
it will have to
Um,
be combined
joint
effort, I guess.
Yes,
Yes.
yes, absolutely. Um, the last question, of course, is always, what is your message to society? What would you just tell people as a geneticist? What is it that you wish people understood better? What can we do better um, to prevent and diagnose disabilities?
So in genetics, prevention is the core of genetics, and that any means by which you can identify a risk, a genetic susceptibility, act on it, get yourself tested, and ensure that your offsprings, your next generation is healthy by practicing prevention.
Thank you so much for your time, Dr. Mamta Murugan. It has been very enlightening and really a pleasure speaking to you today. Thank you so
Thank you,
much.
Anita.
Thank you, Team Ekansh, for the backend support. Thank you, MQ Pharmaceuticals, for being our sponsors. And I thank everybody who's watching this episode. I hope that you also enjoy our series as much as we enjoy making all the videos for you. Thank you so much.